We have seen about the management of first stage of labor in our previous video. So continuing with that, the conduct of labor. In this video we will see the management of second stage of labor. As we all know, the second stage of labor is from the full cervical dilation to the expulsion of the fetus. That is the delivery of the fetus. So this is the second stage of labor, and an average time of second stage of labor is 1 hour in primi gravida and about 30 minutes in multigravida. So here we will see management at different stages. One is during the delivery of head. Next would be, so in the delivery of head we will see about the episiotomy. Next is the delivery of the shoulders. Next would be the delivery of the body of the baby, and then would be the ligation of cord. So in this video we will see how to manage each of these stages. As we all know, the strong good uterine contractions along with the bearing down effects of the mother help in the delivery of the fetus. So in the second stage of labor, first let us see about the delivery of head of the baby. We have to know what is crowning. Crowning is the process by which the largest diameter of the head of the fetus reaches the vulval outlet. This is called as crowning. So the delivery of the head is done by a maneuver called as modified Ridgen maneuver. Modified Ridgen maneuver. Let us see how we do that. So here when the vaginal introitus dilates to an average of 5 centimeter or more than that, we insert a gloved hand to exert pressure on the fetal chin, and the other hand should exert pressure against the occiput. So thereby this helps in the delivery of the head of the fetus. Let us see this and understand with the help of a diagram. So this image shows the modified Ridgen maneuver, in which we use one hand to give a forward pressure on the chin of the fetus, and this hand is placed just in front of the anus near the perineum, and we use the other hand to exert pressure against the occiput of the fetus. So performing this maneuver helps in controlled delivery of the head and preventing any perineal lacerations. This is the modified Ridgen maneuver for the delivery of the fetal head. And sometimes, especially in primigravida, the delivery of the head would become difficult, and if the obstetrician suspects that there can be any tear in the perineum during the delivery of the head because of narrow outlet or any other factors, then we can give an episiotomy. So, episiotomy is nothing but we give a cut in the perineum so that it facilitates the easy delivery of the head by making the vaginal outlet a little bigger. So, the episiotomy can be of three types: medial, mediolateral, central or lateral. These are the three types of episiotomy. And a thing to be noted is episiotomy should be given only when indicated. It should not be a routine practice to give an episiotomy. And we prefer giving mediolateral episiotomy rather than central or lateral episiotomy. And this episiotomy is done when the head is crowning. And this should start at the midpoint of the lower vulval rim and it is inclined to the midline by 15 to 20 degrees to either side and directed towards the ischial tuberosity. This is for the mediolateral episiotomy, which is most commonly done, and this is the safest because this avoids injury to the anal sphincter as we go laterally. And the episiotomy should not include the labia. Labia should be spared. So, this is an image showing the mediolateral episiotomy, whereas the image below shows the central episiotomy. The most commonly performed and the preferred one is the mediolateral episiotomy. So, the central episiotomy has certain disadvantage. So, if the incision extends downwards while delivery, it can involve the anal sphincter. So, this is one of the disadvantage. But an advantage is that healing is more perfect. As it is in a straight line. But mediolateral episiotomy has no such disadvantages. And after giving episiotomy and delivering the baby, the episiotomy wound should be properly sutured in layers. And they suture it in 3 layers. So, in mediolateral episiotomy, which should be made at an angle of 15 to 20 degrees from the midline and directed towards the ischial tuberosity. So this is about the delivery of the head. Now coming to the delivery of the shoulder. So in delivery of the shoulders, we should take care of the perineum to avoid any perineal injuries. So the delivery of the shoulder should be undertaken only when the bis acromial diameter engages. Only then we should perform the delivery of the shoulders. So here there will be delivery of the posterior shoulder first, followed by the delivery of the anterior shoulder. Let's see how with a diagrammatic explanation. The first step is we lower the fetal head so that the anterior shoulder gets underneath the pubic symphysis. Then the posterior shoulder gets delivered first. So for that the head should be held in hand and it should be gently raised upwards by giving a gentle traction, so that the posterior shoulder comes out, and then after the posterior shoulder has come out, we should gently pull the head downwards like this in the downward direction, so that the anterior shoulder hitches against the pubic symphysis and gets delivered. This is about the delivery of the shoulders. So always the posterior shoulder is delivered first, followed by the anterior shoulder. Next will be the delivery of the body. The delivery of the body immediately follows the delivery of the shoulder. And it gets expelled on its own. After the entire body is delivered, the baby should be placed between the legs of the mother and is completely cleaned with a dry towel. And the air passages of the baby should be thoroughly examined and cleared if there is any block. By aspiration using a catheter. This is the delivery of the body. Now ligation of the cord. Now we follow what is called as delayed ligation and delayed cord clamping. This is nothing but the cord should be clamped after 3 minutes of the delivery of the baby. This is because it allows an additional of 80 to 100 ml of maternal blood to the fetus in these 3 minutes, from which the fetus gets 50 milligrams of iron. So it decreases the incidence of iron deficiency anemia. But in case of RH isoimmunization, we should perform early cord clamping to decrease the risk of the alloimmunization. So, in RH isoimmunization, we should perform early cord clamping. And now let us see how to ligate the cord. One ligature should be applied 3 to 4 centimeters from the umbilical end of the cord, and the second ligature is close to the vulval outlet, and then the cord is divided close to the umbilical ligature. That is the first ligature. And after cutting the cord, we should examine the cord to see that there is no bleeding, and to check for the umbilical arteries in the umbilical vein. And the cord is left to dry on its own and it falls off, and there is no need to cover the cord in the baby. So, as soon as the baby is born, the baby should again be cleaned, especially the eyes, lids should be wiped clean, and the baby is wiped with a dry pre-warm towel. And then the first towel is discarded, and then the baby is covered with another dry pre-warm towel. So, this is called as two towel technique. We use two towels for cleaning and for covering the baby. This is the two towel technique. This is all about the management of the second stage of labor, in which we have seen about the delivery of the head, shoulder, body, and then the ligation of the cord. That's it for this video. Thank you.